Thank you very much. So thank you to Yezin and Quesmed and also Savannah and Study Hub for inviting me for this session. So my name is Anath Vijendren. I'm a consultant ENT surgeon based at the Lister Hospital in Stevenage in Hertfordshire. And what I was going to try and go through today are just some single best answer questions that are fairly common in ENT. And hopefully these are ones that will be relevant for your exams, and hopefully they'll also carry you forward when you start in clinical practice. So we'll talk about some of the questions, we'll go through the answers, and then maybe Savannah, if we, I don't know whether you want to do questions as we go along, or do you want to do it at the end? I'm happy either way. So without much delay, I think Yezin's already talked a little bit about the stuff he wants to do with Quesmed. So without much ado, we'll dive in straight to the first question. So I'll give you guys 30 seconds or a minute or so just to have a read and to come up with your answer. Savannah, you've got the polling on, I understand. Is that correct?
Yeah, I'm going to give it about 15 seconds and then I'll launch it just in case it blocks.
Okay, and I don't know. And can I see the polled answers, or would you tell me what they are?
Yes, you'll be able to see them once I publish those.
Okay, that's fine. Just tell me when you want me to carry on. Okay, that's good. So I think most people seem to have got the right answer, which is great. I'll just try and minimize this so I can move on. Okay. Okay, so we'll just quickly go through the scenario. So a 10-year-old boy presents to GP, reports some discharge from his left ear for the last couple of days. It's itchy, but it's not really that painful. And they went swimming a week before. And this is something new for the boy. When you have a look in the ear, there's some discharge in the ear canal, and it appears inflamed, but the eardrum is intact. So from the scenario itself, this points towards an infection, or the beginnings of an infection of the outer ear canal, and that is termed otitis externa. So the treatment for otitis externa at the initial stages is to try and avoid any water and to use topical antibiotic steroid drops. So I think most of you have got the right answer, which was C. And we can quickly go through the other options. So microsuction is something you do when the discharge builds up too much and the drops then stop being effective, so you have to clean it off. And that's normally done by us in ENT. So that's normally kind of the point where we see them in an acute ENT setting. The acetic acid drops are effectively an anti-inflammatory drop. So they're quite good at a very beginning stage, but not quite when the infection is already sort of settled in. Oral antibiotic doesn't have a role in otitis externa, and I'll come to that in a bit and explain why that is. So otitis externa is effectively infection of the outer ear canal. Now, your ear is divided into three parts. You've got the inner ear, the middle ear, and the outer ear. The outer ear is lined with skin. The middle ear is lined with respiratory mucosa. So when it comes to skin, unfortunately, systemic antibiotics, be it oral or intravenous, doesn't really work very well. So the treatment is almost always topical, and topical meaning drops. So in a mild to moderate case, you normally just try and use topical drops, as we've seen in the scenario. When the discharge gets quite a lot, or sometimes the ear canal becomes very swollen and very painful, and at that point, what you need is to try and splint the ear canal open so that you can then get drops beyond where you can see, so that the drops then get in quite deep and they work effectively. Now, we've got a few methods of doing this. The commonest is by using a ribbon gauze known as a Pope wick, but you could also use ribbon gauzes impregnated with antibiotic steroid creams. You could just use antibiotic steroid creams. There are lots of options available. Now, I said systemic antibiotics doesn't really have much of a role, but it does have a role. So there are occasions where treatment needs to go beyond the topical antibiotic remit. And these are normally when you've got a spreading cellulitis. So then we normally start them on either oral flucloxacillin or augmentin. If it goes beyond that, then they need admission for intravenous. Sometimes the infections can be really severe and it starts spreading to the underlying bone. Now, if you all sort of just gently touch your ear and just put your finger gently inside it, you'll feel that there's a bone in there, and that's a temporal bone. And if the infection is uncontrolled, or in particular people who've got certain risk factors, such as diabetics or immunocompromised, it spreads the bone and then it becomes osteomyelitis, what we term lateral skull base osteomyelitis. And this has got quite a high morbidity and quite a high mortality. So you have to hit this quite hard, quite aggressively, and they need prolonged treatment. If infections go beyond that, it can even spread to the brain, and then you need antibiotics or surgical treatment. Usually it's joined between us and neurosurgeons. And then obviously the morbidity goes up. So, it starts the mild spectrum, but it can go pretty dire. Before we move on, I don't know whether, Savannah, what do you want to do? You want to do questions now, or should we do it right at the end?
If we do questions at the end, the Q&A pops up. If someone has it's up to you really. Someone has a question now, or we can wait till the end.
We could probably do 1 or 2 questions, can't we, after each sort of topic, and then that way we'll, we pass the topic. So why don't we do the Q&A?
So if you go to the bottom part, you'll see Q&A.
Yeah, okay. So the question by Priyesh is, for malignant otitis externa, is it Cipro or flucloxacillin first line? So most of the malignant otitis externa as a skull-based osteomyelitis are generally pseudomonal in origin. So we tend to use tazocin or sometimes gentamicin, and we normally couple that with oral Cipro. And it's usually in concordance with what our microbiologists advise. So every hospital has got a slightly different microbiological policy. So I suggest you check with them, but the commonest drugs are tazocin, gentamicin, ciprofloxacin, sometimes cephalosporins. We've got another one by Jacob. When is acetic acid on its own enough? I think this is only when you've got very mild irritation and there isn't really much inflammation or discharge you see, then it's fine. And you can even buy it over the counter, things like ear calm sprays. Okay, so shall we move on to the next one? So again, I'll give you guys some time, and then when the polls are up, we'll go through them. Okay, so great stuff. So from the polls, most people have answered A. There's some who answered B as well, and there's a few C, D's, and E. So we'll go through the scenario. So the scenario is an 18-year-old who presents with a one-day history of left-sided ear pain or otalgia. Unfortunately, it's stopping her sleeping. She feels her hearing is down, but she's otherwise fit and well. She's had a cold a few days ago. And when you look in the ear, it's red, hyperemic, and it's bulging. From this scenario, the diagnosis is quite likely an acute otitis media, or in simple terms, an infection of the middle ear. In this case, now it's important to remember the vast majority of middle ear infections are viral in nature. Now remember I said that the lining is respiratory, hence the same bugs that kind of affect your upper respiratory tract and your lungs, viral infections, and also bacterial ones, are the ones that cause acute otitis media. So from a viral point of view, it's usually parainfluenza or respiratory syncytial viruses. From a bacterial point of view, it's generally Haemophilus influenza, strep pneumoniae, and Moraxia catarrhalis. Those are by and large the commonest ones. Now, because the vast majority are viral, you normally treat it conservatively. So analgesia for pain, making sure they're well hydrated, and just keep an eye on their observations. And that settles things in the vast majority. Oral antibiotics has a role, and we normally give that if they're still struggling after 5 days or so, or sometimes if they've got complications, which I'll go through shortly. A myringotomy and drainage is when you make a tiny cut in the eardrum and you drain the inflammation. And again, it's got its role if it's persistent. So if it goes on beyond a week or 2 weeks and it's not improving, or again, they've got a complication, which I'll talk about. Topical antibiotics, unfortunately, doesn't really have a role. It's effective for the outer ear infections, but it doesn't really help for the middle ear ones. No treatment is, again, an argument. But if the patient is struggling from pain, then I think simple analgesia is probably the best way forward. So otitis media effectively tends to come after someone has had a cold. So the eustachian tube, which if you can see my cursor, is a tube that connects the back of the nose to the middle ear. So when you have a cold, bugs can translocate into the middle ear, and that kind of causes an inflammation and infection. And the commonest signs are a bit of hearing loss, pain, sometimes you get a bit of ringing. Those are by far the commonest. And what tends to happen a lot of the times is that the pain gets very intense, and then the ear pops. And then they get a sudden relief of this pain because the pressure has built up so much in the middle ear that it's perforated the eardrum, and all the discharge comes out. And then people normally experience a bit of a discharge in a bloody ear. So trying to differentiate the middle ear and outer ear infection, the history can make a very important distinction, because if you have pain before discharge, it gives you a bit of a clue that it could be middle ear. Obviously, you need to examine the ear as well. But if you have discharge first and then the pain comes a lot after that, then it's likely to be an external ear infection. Now, glue ear is a slightly different condition. This is more of a chronic problem, and it's because of the immaturity of the eustachian tube. In young kids, you've got short, narrow tubes that tend to be straight. And as we all grow older, these tubes get longer, wider, and they become more obtuse in angle. So as a result, they don't work so well. And what happens is that you've got a buildup of negative pressure within the middle ear, and that causes the lining of the middle ear and the air cells around it to start producing fluid. Sometimes it's serous, sometimes a bit more mucinous, and because it looks like glue, the common term is glue ear. The actual medical term is otitis media with effusion, or OME for short. And a lot of these kids then go on and have either grommets or they have hearing aids, depending on what they require. Chronic otitis media is a very distinct category. So a chronic otitis media is usually a sequelae as a result of immaturity of the eustachian tube over years. So most kids would have grown up of eustachian tube problems when they sort of reach their teen or preteen years, but some people don't. And as a result, they always have this negative pressure, and then they are predispose themselves to either having retractions of the eardrums or holes in the eardrums, or buildup of what we call squamous tissue or wax in another cord that then develops into something called cholesteatoma, which is what we deal with a lot as ENT surgeons. So that kind of sums up a lot of different distincts of otitis media. So a vast majority are self-limiting. Most people don't need antibiotics. You can use delayed antibiotic strategies, and GPs do this a lot. So if someone goes with their children to see a GP with an acute otitis media, they may be given a prescription and said, okay, well, wait till about 3 to 5 days, and if it's still going on, then start the drugs. And then anyone who gets systemic complications need to be admitted. So this is probably what presents to hospital, and this is probably what we as ENT surgeons see more often, because the vast majority of acute otitis medias are dealt with either at home or in primary care. So you can broadly divide them into intratemporal, which is sort of within the ear, or extratemporal, or outside the ear. Or you can even do intracranial, extracranial. It doesn't really matter as long as you divide it in a systematic way. And that's quite important when you sort of do your vivas and your OSCEs for clinical sessions. So within the ear, you can affect the facial nerve because the facial nerve courses through the ear. You can get mastitis, which is an inflammation of your mastoid air cells. That's located sort of just behind where your external ear is. You can get what's called petrositis, which is inflammation of the petrous apex of your temporal bone. And that gives you it knocks off your abducens nerve and your trigeminal nerve, and it makes you very unwell. Or you can get what's called labyrinthitis, although this is a very non-specific term, but effectively what it means is that you get dizziness that lasts for weeks. Extratemporal, you can get meningitis because, again, the infection can spread from the ear through the vessels within the bones in the ear to the brain, or even just a direct extension because the temporal bone is thin, and just beyond that is your dural lining. You can get things like sigmoid sinus thrombosis. So the sigmoid sinus courses through your mastoid, and if the inflammation spreads a bit further, you get a thrombosis of your sigmoid sinus, which can then spread to the brain or other parts of the body. You can obviously get brain abscess, as what this picture has shown. And you can get sort of other abscesses in other areas within the head and neck and parapharyngeal spaces. So a Basol's abscess collects within the sternocleidomastoid mastoid. A Satellis abscess tends to collect within the digastric ridges, so that kind of comes up just around this area. And you get a Lux abscess, which kind of collects in your zygomatic arch, so that's kind of around this area. So various abscesses you can collect. Any questions about otitis media? So there's one on how to tell the difference between a discharge from perforated eardrum and a discharge from a previous case. So sometimes it's hard to make the distinction, which is why the clinical examination is important, and also the history. So if the history is if the history shows that the pain is before the discharge, then it's quite likely it's otitis media. If you look in the ear and there's a swelling and a thickening of the ear canal wall, or a severe narrowing, there's likely otitis externa. So use a combination of the tools, history and examination, to tell you. So there's one from Lagastija about would you mind explaining how the negative pressure causes the fluid to leak out? So effectively, the fluid doesn't quite leak out. What it does is the negative pressure causes a buildup of fluid within the ear. And then in an acute otitis media, what happens is the fluid really builds up, and then it just perforates the eardrum itself. In glue ear, perforations don't really happen because it's not a high pressured system as it is in acute otitis media. And the reason why the fluid is produced is because the lining is kind of devoid of oxygen, and hence its reflexive mechanism is to sort of produce fluid. So Basol's abscesses and Satellis abscesses are not very common at all. We rarely see them, very rarely, but they do happen. And which nerves are affected with pityriasis? So it tends to be the abducens nerve, the trigeminal nerve, and sometimes it can be the oculomotor. So those are the sort of the former two are the commoner ones. Okay, let's move on to the next one. Okay, so it looks like most people have answered C. There's some B as well. So some vertical nystagmus, mostly rotary nystagmus. So we'll go through the scenario. So this is a 70-year-old who feels dizzy and the room spins around for about a minute. When she turns onto her left side of the bed, she feels sick when it happens. And then when it stops, she feels fine. Tuning fork tests are fairly unremarkable. She's got a background atrial fibrillation, but she's been well. And what would you observe in the Dix-Hall pike? So the history suggests a rotary vertigo, which is when the room's spinning around, that lasts for a minute, okay? There are a few conditions that give you this, and I'll go through them very briefly, but the commonest of which is BPPV, or benign positional proximal vertigo. Now, BPPV is quite common. It happens from lots of different reasons. The vast majority are idiopathic, but it can happen after an infection, after trauma, after you've had surgery, after something that's been stressful. And effectively what happens is you've got dislodged particles within your inner ear, mainly within the posterior semicircular canal. And these particles sit in an area called the ampulla, but what happens is it gets dislodged, and then when people move their head around, the particles, or otoliths, that's a medical term for it, they kind of bounce around your canals and they give you this quite severe vertigo. If anyone has had it, it's actually quite disabling. And the Dix-Hallpike test is a diagnostic test where you basically hold them sitting upright and then you very quickly move them downwards with your head extended. And what you see is this characteristic geotropic rotary nystagmus. And they kind of just last for split seconds. There's a bit of latency to it, and then it peaks up, and then it dies away quite quickly. So there's a few characteristics of the nystagmus which are important. So that's a classical. I mean, I don't think A is much of an option. Vertical nystagmus happens for lots of more central causes, so neurological causes. It can also happen in things like alcohol abuse and certain medications you take. A Dix-Hallpike is contraindicated. So a Dix-Hallpike is normally contraindicated if you've got, for example, issues with your neck, or for social reasons. So if someone has come to your clinic alone and they're driving back, then I probably may not, do it, because, I might offer them that they sit and hang around for an hour or two after, because it can make them feel quite sick afterwards. And especially if they're driving and they're elderly, you want to make sure that a lot of all these thoughts are running through your head before you go ahead and do it. Dysdiadokinesia is generally a sign of cerebellar pathology. So again, it's not quite indicated in this. Now, I'm going to talk very little bit about dizziness, but I just want to explain that dizziness is a very sort of broad, encompassing term. So we can spend hours and hours talking about this, but it's just a few salient points that I want you guys to take away with. I'm going to focus particularly on vertigo, because vertigo is where we as ENT surgeons come in. Now, what is vertigo? Vertigo is effectively a hallucination of movement that is predominantly rotary. So, if any of you, by any chance, have ever been, had too much alcohol at any point, then you may recall that at some point, the room starts spinning around. And that's effectively what vertigo is, except that patients who have it, are quite disabled by it and haven't had the pleasure of having any alcohol before it starts, the vast majority of cases. And it's effectively, you get this sort of spiral-like rotary picture. So it's very important when you take a balance history that you try and find out what sort of dizziness they encounter, because dizziness could mean many things to many people, and vertigo could mean many things to many people. And a lot of times when patients come to see me, they tell me they're experiencing vertigo, but what they actually describe is more syncope, or they feel a little bit just lightheaded. So I try and always get them to explain it in plain words rather than using any form of medical jargon. And I tell them, don't use the word dizziness, just use a different word to describe it. Now, when you're trying to diagnose vertigo, the most important thing is the timing of the incidence, okay? So if the vertigo and only the vertigo, so it's common to have vertigo and then have a bit of dizziness afterwards, but that's not what we're after. We're after just purely the vertigo. If it lasts seconds to minutes, then it's usually BPPV, the commonest, or something called superior semicircular canal dehiscence, where it's a very rare condition and you basically have an erosion of your superior semicircular canal bone. And you have a few other symptoms like pulsatile tinnitus and autophony that comes with it. If it lasts for hours, then the commonest is what we call vestibular migraine, or migrainous vertigo, which is basically migraine of the inner ear. And I'll talk about that shortly a little bit. Meniere's disease is something that everyone's favorite, but in actual fact is very rare. And it's a diagnostic criteria for Meniere's. It used to be just a triad of oral fullness and tinnitus and vertigo and hearing loss, but that's not quite how you diagnose it. There's some very specific symptoms and signs that need to be part of the diagnostic criteria. If the vertigo lasts for days to weeks, then you're looking at either vestibular neuritis or vestibular failure. And this is a broad term that also incorporates labyrinthitis. Okay, so it's all classed under sort of vestibular neuritis or vestibular failure. Cerebellar-pontine angle tumors are benign tumors that sit on the hearing and balance nerves, and they can give you dizziness. Sometimes when we do surgery, either intentionally or unintentionally, you can get dizziness as a result of it. There are psychosocial conditions that can make you feel dizzy constantly, and you get vertigo lasting for a long time. And one example is something called PPPD, persistent postural perceptual dizziness. And of course, don't forget medications. Now, if you look into your BNF, or if you are on any medications and you take a look at the side effects on the sheet, you know, it's very likely you'll find dizziness as one of the side effects. So it's extremely common. And sometimes you may be on a medication for a long time, been absolutely fine, and then something changes in your either personal circumstance or social status, or even in your medical history, and then the dizziness starts. So I'm not saying the medications cause it, but they're certainly a contributing factor to the experience of it. Now, very briefly, BPPV, so we talked about that. It's, you know, it lasts seconds and you turn over, but you can have the dizziness that, you know, the sort of imbalance, feeling a bit off legs and feeling a bit weird, oozy for a few hours afterwards. But it's that pure vertigo history that we're after. And it's caused by otholates in the vestibules of the semicircular canal. The commonest is posterior semicircular canal. You can have it in the anterolateral, but it's very rare. And the Dix-Hallpike is almost always diagnostic. And the management is, well, you can basically do a few things. You can either wait for it to subside, and the vast majority of this will subside, although a lot of patients are very symptomatic, so that's not what they're looking for. There is a maneuver called the Apley's maneuver, which is worth having a look on YouTube, and this is curative in 80% of patients. Sometimes they may need more than one or two, but it's very curative. And there's also exercises such as the Brandt-Daroff exercises, which can be quite helpful. So I want to talk a little bit about vestibular migraine, because this is a lot more common than you think. And it can happen in people who do have migraine and also those who don't have migraine. But these are effectively the diagnostic criteria. So you either have a current or past history of migraine, you've got quite severe vestibular symptoms that last between 5 minutes and 72 hours, and at least half of them are associated with either migrainous headache, photophobia, phonophobia, or visual aura. And at least 5 of the episodes fulfill the above criteria, and they're not better accounted by another diagnosis. And we kind of treat them very similar to migraine. So we either do abortive treatment. So if they're very infrequent, we only treat them as and when they happen with triptans and non-steroidals. Or you can look at doing preventative measures if they are frequent enough and the patient wants to look at it. And then there's an options of between beta blockers, tricyclic antidepressants, or even SSRIs. So you try and marry this up with, you know, the patient's comorbidities or what sort of other symptoms they have. A lot of patients with migraine have a lot of anxiety, for example, and I tend to use venlafaxine for those patients. Some patients have got high blood pressure, and hence propranolol or metoprolol may be a better suit. So you kind of, you know, you chop and change depending on which patient, what the patient's history is like. Meniere's disease is a disease has been around for a long time, but I can't say that we know all about it or all too much about it. What we do understand is that it's to do with the pressure buildup within your endolymphatic sac and your scala vestibuli, and scala media, which carries endolymph. So it's a buildup of the pressure. We don't really know why it happens, although it can happen as a secondary to some other conditions, or sometimes as a result of surgery. And what happens is when the pressure increases, you get this combination of symptoms. And this is effectively how you diagnose it. So it's divided into 2 distinct types. There's a definitive Meniere's and a probable Meniere's. And a definitive Meniere is associated with 2 or more episodes of vertigo lasting 20 minutes to 12 hours. You have these hearing loss that's documented on a pure tone audiogram. That fluctuates between time, and it tends to be worse when they have their attacks, and then it's fine when they're not. And they also get oral symptoms, which is hearing, tinnitus, and fullness in the affected ear. And there's no other better diagnosis to account for the symptoms. Probable Meniere's is sort of similar, except that it doesn't have the documented hearing loss, and it lasts for longer, 20 minutes to 24 hours. So, you know, the history is a bit vague from the patient. So you can see how a lot of this is very similar to vestibular migraine, and is very easy for people to get them confused, which is why you have to ask specific questions. And you need to have an audiogram, a hearing loss, and effectively you need to have an MRI of their head and their internal acoustic metastasis, because remember, all of these have stated not better accounted for by another vestibular diagnosis. So you need to exclude the other stuff before you can come to these conclusions. Now, their management is varied. There's a lot of things described in the literature, okay? So the conservative ways are trying to avoid stress, salt, sorry, I forgot to put that in. So salt, caffeine, and alcohol. The medical therapy, there's been a lot of debate about this over the years. So there's talks about thiazide diuretics, antiemetics, beta-histine. Now, from what we know, there have been good amounts of studies to show that none of these really work all that well. But anecdotal experiences show that a lot of patients report good improvement with beta histine, and it's a very safe drug. So most of us still use beta histine as a first line. And then the other options include intratympanic steroid injections, hearing aids, and invasive surgery, which can carry the risk of them losing their hearing completely, and it can make them quite dizzy for a week or two. So it's not light surgery. Now, the only thing of all the management options that has good amounts of evidence is intratympanic steroid injections, which are shown to decrease the number of attacks they have and improve their quality of life. So that's definitely something we offer more and more these days. Now, labyrinthitis, vestibular neuronitis, vestibular failure, it's caused by lots of things. So we can't say it's purely infective because we don't culture the areas, we don't grow bugs from the areas, which is why we moved away from the term itis, because it's thought to be an inflammation infection, which we don't really know it is. What we think happens is that something happens to either the blood supply to your balanced organs, or something happens in the nerve pathways. And this causes it to shut down temporarily most of the time. And it's almost always associated with the viral illness, but it can also be from stress, it can be from surgery, it can also be in people who've got risk factors for sort of vascular-like diseases. So if you've got diabetes, if you're hypertensive, if you're known to have heart transplant, a heart block or stents, these conditions obviously will affect vessels throughout the body, and the vessels that supply your inner ear are fine, and they are single, so there's no collateral. So if you knock that vessel off, that's it, effectively. So the treatment is pretty much symptomatic. So you help them with their dizziness and their vomiting by giving them some Stemetil. And then as time goes on, you need to stop those drugs because it impairs rehabilitation. You need to get them to do some exercises. So vestibular physiotherapy is very effective in these ones. Very quickly, to try and distinguish between central and peripheral nystagmus, you can use a HINS mnemonic, and this is something that the guys in A&E do to distinguish between a sort of vestibular course to vertigo or a brainstem / cerebellar course to vertigo. So head impulse is when you try and move your head quickly and your eyes should move along with it, and if that doesn't happen, then there's likely to be a problem with your vestibular system. So if you've got a normal head impulse test, then in a patient who's got vertigo, it points to it possibly being central rather than peripheral. Nystagmus, if something is vertical or gaze-induced, then it's likely to be central. And a test of skews. So skew is when you cover one eye and the other eye then quickly changes vertically to try and make a correction. And if that happens, then you've got a central problem again. So these are, quick tests you can do at the bedside to try and distinguish between central and peripheral nystagmus. So should we take one or two questions on that? So is rotary nystagmus the same as horizontal? No, it's not. They're two different things, unfortunately. Rotary is when it turns around, and horizontal is when it kind of moves that way. So with horizontal, next man also go with the correct answer. No, it's not. So it has to be rotary. That is the rotary is the classical. That is the classical sort of BPPV one. So interesting. ENT consultant I was speaking to told me there's no such thing as vestibular migraine, whilst another told me there was. Just wondering why there seems to be a lot of contention around it. So it's a relatively new diagnosis. When I say new, I mean it's been around for about, I'd say 5 years. So it's not something that lots of people are used to, but it's certainly something we are seeing more and more. And the reason for this is because they're responding to the anti-migraine medication. So there's no diagnostic test for it. It's purely on clinical grounds. And then you kind of get the diagnosis when they respond to the medications. So the Barony Society and the international sort of balance societies have certainly recognized that it is definitely a cause. And I think it will become more and more prevalent, more and more accepted as time goes on. So red flags will probably be cerebellar signs. So if you have a patient who's got ataxia, nystagmus, dysdiadokinesia, past pointing, then I'd be very worried this is a stroke. And also the HINS test is a very good way of trying to distinguish these ones. So basically the major red flag is a stroke, a brainstem stroke. You can get some tumors that also cause these conditions, but most of these tumors are non-malignant. They're mostly benign tumors and they're slow growing. So they're not quite something you've got to rush into. So in Meniere's, it is a sensorineural hearing loss and not a conductive hearing loss. Okay, interesting question about electrocochleography. Yes, it's been classically used to diagnose Meniere's disease, and what you get is a difference between a stimulating potential and an action potential, but it's not purely diagnostic, which is why it's not made into the diagnostic criteria. So there are lots of tests that you can use to help diagnose Meniere's disease. One of them is a gadolinium enhanced MRI scan, but again, it's not something that is 100% proven in every case, which is why it's not made into the diagnostic criteria. As time goes on, it probably may be, but not now. So if they only get sensible hearing loss during the attack, is it practically difficult to get an audiogram? Very, very difficult to get an audiogram during the actual attack. And what we do see is that they come in and have it after their attacks. And sometimes, because they've had a lot of attacks, they just have a permanent hearing loss on that side. So vestibular neuritis, viral labyrinthitis, effectively they're the same thing. I would just stick to a single term. We stopped using the term labyrinthitis anymore. We just use either vestibular failure or vestibular neuritis. And the prescription, and what do we prescribe for dizziness? It depends what the cause is. Whether it's vertigo in an acute instance, you can use things like Stematil, which is chlorperazine. It's an antihistamine. You can use cinnarizine, which is also an antihistamine. Beta histamine is something you only use for patients with Meniere. So unless they've got a proper diagnosis of Meniere's, I will not start patients with beta histamine. Okay, shall we move on? Otherwise, you might get very bogged down with dizziness, because it's a very interesting topic, and I think lots of people struggle about it. So next question. Okay, it looks like pretty much everyone's got the right answer. Well done. Okay, so the scenario is a 64-year-old gardener comes in a neck lump. It was incidentally discovered. He denies any dysphagia, dynaphagia, hemoptysis, or weight loss or loss of appetite. He's a smoker with a 20-pack history. He drinks a pint of beer every day. He initially has been having some intermittent earache in the right ear. It's been going for a month, but he's a bit more concerned about the neck lump, and you feel a fixed heart lump in the anterior triangle. So pretty much the entire story screams something to be worried about. Yeah. So this is something that we would send as a 2-week wait or cancer wait referral to ENT. So unfortunately, yeah. So the rest of it is not quite appropriate. Now, just to touch on some of the things very, very briefly. So one of the biggest risk factors for head and neck squamous cell carcinoma is obviously smoking. With oral cancer, it's betel nut chewing. And there's also something else, which is HPV induced. So we see a lot of that in oropharyngeal cancers, which involves the tonsils and tongue base. And those respond quite well to chemoradiotherapy. Now, someone with an unilateral ear pain in an absence of any ear finding, so if you look in the ear and the ear is completely normal and they've got earache on that side, is always a little bit concerning, particularly with this story. So they almost always need to come and see us to make sure there isn't something going on. You obviously have to take a proper history and examine them thoroughly, because you can have problems like temporomandibular joint dysfunction causing issues in the ear. Very rarely you have things like eustachian tube dysfunctions, but by taking a thorough history and asking them all the relevant questions, you can sieve that out. And also you want to find out about whether they've got any changes in your voice, swelling problems, pain and swallowing, difficulty swallowing, weight loss. All of that will give you an idea of what the cause of the earache is. But the take-home message is earache in a normal looking ear, in a slightly sort of middle-aged gentleman, not normal, definitely needs investigation. So I think we've got another question. Okay, so we've got 50% answering A and 46% answering C. So let's see what the answer is. The answer is C. Okay, so let's go through the scenario quickly. So 58-year-old driver presents the lump in the neck. He first noticed it after recovering from a cold 2 months ago, and he reports no change in the size of the lump. He is otherwise well in himself. There's no other symptoms of dysphagia or dynophagia, weight loss, or loss of appetite. It's a heavy smoker, drinks alcohol daily. An examination, you feel a hard fixed lump, the entry triangle of the neck, and which is the most best investigation. So again, on examination, the lump is suspicious. He's a heavy smoker. He's sort of middle-aged, so you'd worry that this could be cancerous. Now, although getting a CT head neck, head not so much appropriate, but getting a CT neck and thorax is something that we tend to do. But it's not the first investigation, and it's certainly not the one that you want to go for right at the beginning. What you want to do is ultrasound the lump to define the characteristics of a lump and take a fine needle aspirate of it. So that will give you effectively a triple test, which is history examination, radiology modality, and cytology modality. So you've got 3 methods there of trying to determine what this lump is. If the lump comes out as cancer, then yes, you would then go on to do an MRI neck and a CT chest for further imaging. But it's not always something we do right at the beginning. Obviously, if we are strongly suspicious, then we might jump the gun and go ahead and organize all the investigations to try and save some time. But that depends on our level of suspicion. So yeah, so the first answer, for the purposes of your MCQs, if the question is asking for the next best investigation, I'll definitely go for an ultrasound or an ultrasound guided fine needle aspirate. An X-ray of the neck doesn't serve much purpose in head and neck skin cancers. PET CTs are a useful modality to try and identify if they've got a very aggressive disease, is there any distant spread? Or if there's a lot of inconclusiveness about where the cancer is coming from. So if you've got a neck node that's positive, but on examination and an MRI scans, you can't find out where it's coming from, then a PET CT will give you a bit of an answer. What PET CT does is it uses FD glucose, so fluorodeoxyglucose, try and pick up hotspots where there's metabolically active disease. So unfortunately, if someone has an infection, it'll also pick up as a hotspot. So they have to make sure they're infection-free. Radioactive iodine uptake test is irrelevant for head and neck cancers. It's got a role to play in thyroid cancers, but not in squamous cell carcinoma. Okay, so very briefly to talk about neck lumps, I think the take-home message I want to drill into you guys is trying to make sure that when you describe a neck lump, you can identify the site where it's coming from, the characteristics of it. So what does it feel like? Can you feel the borders? Can you feel the edge? Does it feel fixed? Is it mobile? Is it hard? Is it soft? Is it tender, non-tender? Is there a pulsation? Is there any transluminability? Is there any overlying skin changes? That description is probably far more important. Now, I mentioned site as the first thing because site gives us a very good idea of what it could be. And if it is cancer, then where is it coming from? Now, in the past, we used to use anterior posterior triangles to a greater extent. We've now started using levels of the neck, and this is what we use to sort of describe the lump, both clinically and radiologically as well. So an anterior triangle is effectively anything of the anterior border of the sternocleidomastoid, anything in the midline of the neck, and anything along the base of the mandible. And that sort of triangle is your anterior triangle. Okay, and your posterior triangle is effectively the posterior border of your sternocleidomastoid, the anterior border of your trapezius, and the upper part of your clavicle, and that's sort of your posterior triangle. What they have done now is they divided it into the levels 1 to 6. There's even a level 7, which is sort of pretracheal. I won't go into that. So level 1 is effectively where your submandibular area is. It's bounded by the mandible and the anterior and posterior bellies of the digastric. Level 2 is effectively along the upper part of the sternocleidomastoid, so from the skull base all the way up to the level of your hyoid bone. Level 3 is effectively between the hyoid bone and I'd say the cricoid cartilage, and then anything from the cricoid cartilage towards the clavicle will be level 4, and this is along the sternocleidomastoid. And level 5 effectively is the formally posterior triangle. And you've also got level 5A and 5B, which is divided by the spinal accessory nerve, as you can see coming through here. So 5A is above the spinal accessory nerve, and 5B is below it. So I think that's definitely a lot more effective. And if you come to your exam saying I can feel a lump in level 2, obviously you need to know where level 2 is, because the examiner might ask you, well, tell me where level 2 is. So if you tell someone I can feel a lump at level 2, that's more specific to this area, and then your list of differentials also drop down very quickly, whereas an anterior triangle is a very broad area. So you could still be stuck with the list of differentials. So I'm not going to ponder on this too much, because you can read a lot into it, and there's obviously hundreds and hundreds of neck lumps that can present in every area. And head and neck cancers, depending on where they arise from, can give you metastatic lymph nodes in anywhere between level 1 to level 6. So the vast majority of level 6 are usually usually thyroid metastasis. Level 1 tends to be oral cavity, but there's also a lot of cross overlap, and certainly from the nasal cavity, from the pharynx, hypopharynx, larynx, they all can sort of present within 2, 3, and 4, sometimes even 1. And then don't forget there's lots of benign nodes as well that can come into the region. So things like sebaceous cysts, lipomas, which is why having a system to characterize these things are very important. And everyone's got a different way of doing it. So stick to whatever you're good at. It doesn't matter. There's no one way of doing it. Just find one that you feel is most comfortable for yourself. Now, neck masses as malignant until proven otherwise. There's a caveat to this, because not all neck masses are malignant, but certainly if you treat them as they are malignant to start off with, then you're never going to miss one and you'll never go wrong. So it's a good way to start thinking about that. The risk factors are, as we mentioned, smoking, alcohol, HPV status. EBV, Epstein-Barr virus, has got a major role to play in nasopharyngeal carcinoma, and beetle nut, again, in all cavity cancer. So the red flags are hoarse voice, dysphagia, odynophagia, a unilateral blocked nose, and epistaxis. This is interesting. So if someone has bleeding from one side and a blocked nose, that's certainly something you need to worry about. And certainly I've just had a patient with melanoma up their nose just this week. And, she presented exactly with that, a unilateral blocked nose and epistaxis. Unilateral otalgia, as we talked about. Unilateral glue. Now, the reason for this is because masses in the back of the nose. Remember I was saying the eustachian tube connects your back of the nose, or the postnasal space, with the middle ear. If you have a mass in the back of the nose, i.e. in your nasopharynx, they will block off your eustachian tube and cause glue on one side. So if someone's got glue on one side, they need to have a camera up their nose to make sure there's nothing going on. And systemic features, of course, if they've got weight loss, night sweats, anorexia, etc. A good investigation starts with examination. So you want to examine the ear, the oral cavity, the oropharynx, the nasal cavity. You want to do flexible nasonoscopy of the tongue base, larynx, and hypopharynx, which obviously is mostly done by us. And then ultrasound is usually the modality of choice. And ultrasound-guided FNA is available in pretty much most hospitals these days. All radiology units are able to offer that, so that's very accessible. Okay, let's move on. Next question. Oh, sorry, was there any sort of burning questions? I think in the interest of time, we'll probably just do 1 or 2. So if I just while everyone is polling up. So interesting. So there's a good question here. Is triple assessment for all lumps you suspect malignancy, or is it just breast and neck lumps? So it's a good question. It's certainly something we do in breast, neck, and thyroid lumps. Okay, so if you have a thyroid lump, it's triple assessment. If you have breast, it's triple assessment. If you have neck, it's triple assessment. Not all lumps in the body you can do a triple assessment on. So for example, for colorectal cancers and stuff, you can't. You need to do a colonoscopy. But if you have an inguinal lymph node, for example, then yes, that's certainly something you can do a triple assessment. So I think another question on question 2, what was the relevance of lump appearing following a cold? I think this is just a red herring. So I think it's something to watch out for, because a lot of patients will be very non-specific with what they say. So they might just say, oh, I noticed it after a cold because it probably got bigger after a cold, but it might have been there for a long time. Again, we haven't proven this lump is malignant, so can't say. Is glue normal bilaterally in child? Yes, it's normally bilaterally in child. Okay, so moving on to our poll. So everyone has answered B, presbycusis, which is correct. So this is an elderly gentleman who comes with hearing loss, and she complains that she has to shout to get his attention and to turn up the television too loud. And the GP is sending for an audiogram, and this is what it shows. So this is characteristic presbycusis, effectively, where you've got sort of normal hearing here, and it tails off the higher frequencies. And the reason for this is because as you get wiser in life, the higher frequencies, which are located in the base of your cochlea. So the cochlea is tonotopic, which means that as it goes along its 2.5 circles, it's got different frequencies, and these are located in the base. So those are the ones that tend to go off first. So that condition is called presbycusis. Otosclerosis is a different condition. It causes conductive hearing loss, and it's to do with fixation of the stapes at the oval window. Meniere's disease we talked about. Bilateral otitis media, again, we talked about. That's usually gives you conductive hearing loss. And noise-induced hearing loss we'll talk about shortly again. Okay, so I'm going to talk to you very briefly about audiogram. It's not something you get a lot of teaching about in medical school, or even as a junior doctor, actually. So it's just to have some basic understandings about it. So if someone was to explain to me about an audiogram in very simple, or if I had to explain an audiogram to someone in simple language, what I would say is that you've got two axes. You've got an x-axis and you've got a y-axis, okay? The x-axis is for the pitch, which is measured in hertz, and the medical term of which is called frequency. The y-axis is for loudness, or the hearing level, or hearing threshold in medical terms. That's measured in decibels. Now, anything 20 decibels and below is effectively normal hearing. 20 to 40 is sort of mild, 40 to 70 is sort of moderate, 70 and 90 is sort of severe, anything beyond is profound. Now, this distinction is quite arbitrary, okay? So it's not, I wouldn't take it too hard. I wouldn't take it as a a distinct fact, but it gives you a good guide. Now, on the audiogram are some symbols, and what you'll see is two different colors. Now, you won't always have colors, especially if you've got a black and white audiogram, but what's more important are these symbols here. So you'll see circles, and circles represent air conduction in the right ear. And you'll see X's, and X's represent air conduction in the left ear. Now, there isn't that information in this audiogram, but if you focus on the side key panel here, there are masks air conduction and there's bone conduction. Now, air conduction effectively measures air transmission from the external canal all the way up to your cochlea, or up to your brain effectively. So it measures your entire hearing pathway. The bone conduction is by a machine that's placed in the back of your ear, and that effectively transfers sound directly from the bone into your inner ear hearing mechanism. So it purely measures the sensory neural component. So to cut a long story short, if you've got a bone conduction threshold and an air conduction threshold that mirrors each other, then the hearing loss is probably more sensorineural, if there is one. If there's a difference between the bone conduction and the air conduction, and the bone conduction is normal, that means the patient has got normal sensorineural hearing loss, but there's a problem with the overall transmission. So you can then surmise that the problem arises because of a conductive hearing loss issue. Now, don't worry if that's not very clear, or you can't remember the whole thing. It will come a bit clearer as we move through the slides, okay? So I've got a few examples here. So we've seen presbycusis, where you've got relatively normal hearing in the low frequencies, and then as you get to the higher frequencies at 2, 4, 8, it tends to tail down. And a lot of these people will struggle with high frequency, high pitch sounds. So for example, female voices, squeaky voices, those are the things they struggle with most. And what happens is, when they're watching TV, they can hear all the low conversations fine, but then suddenly when it changes, they struggle. So the TV volume then goes up. Or you might even, encounter your parents or your grandparents, you talk to them something and they say, sorry, pardon me. And then when you raise your voice, you say, why are you shouting? That's because your pitch changes and their perception of the sound changes. But it doesn't change the fact that they've got a hearing loss. So a hearing aid is very effective for these patients, effectively. And then you've got what we term induced hearing loss, where you get this characteristic dip at 4 kilohertz. We don't really know why that happens, but it's characteristic. And almost always the patient has a history of, loud music exposure, or they've been playing in rock bands, or, they work as a bartender in a nightclub or something along those lines. So going back to the air and bone thresholds, what we have here, you can see the axis, which is the left air conduction. You've got the circles, which is the right air conduction, and you've got these triangles here, okay, which are unmasked bone conductions. And effectively what this shows is that the air conduction and the bone conduction are similar, but they are similar at 50 decibels. So the threshold is at 50 decibels, whereas normal is 20 decibels and below. So they clearly have a hearing loss here. Because both bone and air thresholds are similar, we can surmise that the problem is sensorineural. Hopefully that makes some degree of sense. If you look at this one, for example, so you've got your air thresholds, so your left air thresholds, your axis around 45, your right air thresholds, which is the red, at sort of 50 to 45, and then you've got your bone ones here, and these are masked bone conduction. So the one that kind of looks like your left ear is the left masked bone conduction, or what we call a C shape, effectively. And then the sort of, well, the C shape is the right, and the reverse C is the left. So I kind of just use, well, if you kind of put your right ear to that, you'll see that it looks similar to your right ear in a drawing. And I use that for the right, then the other side for the left. So those are normal, but the patient's got a hearing loss. And there's this difference between the bone thresholds, which only measure sensorineural, and the overall hearing pathway. So you can then surmise that the inner ear is working fine, but there's a problem with the external ear or the middle ear. And then you need to examine the external ear to see what's happening, to give you an idea whether it's coming from the external ear or the middle ear itself. So hopefully that makes some sense. Now, before we move on, let's do 1 or 2 questions from this. Okay, so there's a lot of questions about masked and unmasked. Okay, so effectively, what masked and unmasked is that when you do a hearing test, you basically, I think it's probably worth you guys trying to get into a, if you turn up to, when you guys go into hospital, turn up to hospital and ask your friendly audiologist if you can sit in to see a hearing test. It's quite interesting. So what happens is you go into a really quiet, soundproof room. The audiologist then puts either earphones or headphones onto a patient, okay? And then they give them this buzzer and they'll start playing sounds. And they play sounds, starting at loud, and then they get softer and softer, and then people have to press the buzzer. So on their screen, they can see when they're pressing the buzzer, and they can also tell if people are lying. Now, what happens is when you've got a difference between the right hearing and the left hearing, or when you've got difference between the bone conductions on both sides, you're not sure whether that difference is because of a true hearing loss in this ear, or the affected side, or whether the hearing is actually being picked up by the other ear through a bone transmission. Because there is something called interaural differences between your ears. So, for example, if you hear someone shouting from 2 meters away on your left side, it's not just your left ear hearing it, it's also your right ear that's hearing. Of course, the right ear hears it at lower volume, but it does hear it. So what masking does is it removes the other ear's hearing so that you're only testing that ear that you want to test. So for example, if the right ear, if the patient's right ear has got a big hearing loss, what they will then do is introduce some sounds into your left ear and then get them to do the test again. And then you have a true idea of what the patient's hearing is like. So on audiometry, is air conduction usually higher, better than bone conduction? So no, it's not higher or better, but use it in combination. So you almost always have to do both. And the idea for this, well, you don't have to do both if you've got a normal air threshold hearing, but if there's a hearing loss, then you need to do both, because what you need to find out is whether it's a sensorineural hearing loss or a conductive hearing loss, or sometimes you even may have a mixed picture. So you may have the bone thresholds down here, for example. So there's clearly a sensorineural component, but there's also a conductive component. So what does the characteristic conductive hearing loss audiogram show? So this is, for example, a characteristic conductive hearing loss. And what you see on this is that there's an apparent difference between the bone thresholds, which is normal, so they're kind of around 20 decibels, and the air thresholds. And that means there's a problem with the conductive pathway of sound. And the conductive pathway of sound affects the outer ear and the middle ear. So you can look at the outer ear, you can see whether there's any infections or foreign bodies or whatever, and you have an idea of what the middle ear is like. So if the outer ear is normal, then it's likely to do with the middle ear bones of hearing, or the ossicular chain as we call it. So the drop in noise-induced hearing loss, it's hard to say. No one really knows why, but for whatever reason, noise seems to affect that frequency the most, and it's those frequencies at the cochlea which gets affected the most. So if your air conduction is worse than bone conduction, then is there an issue with the middle or external ear? So if the air conduction is worse than the bone conduction, then it's an issue with either the middle or external ear. And this is where you need to then use your clinical judgment and clinical skills to find out where it's coming from. So characteristics of an audiogram is sentinel hearing loss in the low frequency. So that means bone conduction thresholds and air conduction thresholds will be, somewhere down here. And then normally you have a normal high frequency, but sometimes that can be affected as well. So let's move on to the next question. Oops, sorry, skipping quickly. While you guys are reading through that, is minus 10 decibels possible? Yes, it is. So there are people who've got really good hearing. Okay, so most people have answered A. So it's a 41-year-old who attends ENT clinic complaining of having difficulty hearing. A Weber's test lateralizes to the left. Rini is positive in both ears, which means air conduction is greater than the bone conduction. So what type of hearing loss do you suspect? So it's a right-sided sentinel hearing loss. So I think that's pretty much given. So we'll talk a little bit about Weber's and Rini's. And this is, there's not many things you can be asked about ENT examinations in a Viva. One of it is definitely neck lumps, and the other one would be an ear examination. In an ear examination, you would be expected to do Weber's and Rini's at the same time. So I'll definitely try and get well versed with it. So a Weber's test is basically where you use a 512 tuning fork, because that's the tuning fork which has the vibration that's required to trigger off the vibrations within the skull and the bones of hearing. You place it in the center of your head and you ask them which side do they hear it louder. So if they hear it central, then it means that both ears are kind of equal. It doesn't mean that both ears have normal ear hearing. It just means that they both have equal hearing. Because you could have hearing loss which is symmetrical on both sides, which will give you a normal a Weber that's central. If the Weber goes into one side of the ear, so if it lateralizes to the left side, then it's either a left conductive hearing loss or a right sensorineural hearing loss. That's effectively it. Or sometimes it could be mixed as well. Now you can't use it in. You need to use it in combination with the Rini's. You can't decipher much from it just by using it on its own accord. So a Rini's test is basically where you use a 512 tuning fork. What I do is first I will tell the patient that I'm going to be placing them behind the ear and in front of the ear, and I ask them to tell me which one will be louder. So I place it behind the ear and ask them, can they hear the vibrations? And they say yes, and then I move it in front of the ear, parallel to the ear canal, about a few centimeters away, and I ask them, can you hear it? And then they say yes or no. And then you ask them which one is louder, the one behind the ear or the one in front of the ear. And then if they tell you the one in front of the ear is louder, it means that the air conduction is louder than bone conduction, and that means it's a positive Rini. Now, all that means is that the sound is transducing through your ear canal, middle ear, and into the inner ear effectively. It doesn't tell you whether it's normal or abnormal. Okay, so if they tell you that it's louder behind the ear, that means bone conduction is louder than air conduction. That means that there's a possible conductive hearing loss, which is why sound is being transmitted through bone conduction into your inner ear quicker than it is being transmitted through the air conduction point of view. So I hope that makes sense. So a Rini's positive is when air conduction is louder than bone conduction. A Rini's negative is where bone conduction is louder than air conduction. So you need to use these tests together to give you a bit of an idea of what is happening. Okay, so I won't dwell too much on that. We'll move on in the interest of time. So next scenario. Okay, so we've got a bit of a mixed answer group. So most of you guys have answered C. There's a fair few that also answered B and A. So we'll talk about them. So effectively, 11-year-old boy who comes into A&E with a nosebleed. So he's leaning forward and pinching his nose and he's calm. It started half an hour ago. He's obviously stable. On examination, he's breathing through his mouth. There's no coughing or choking. There's blood dripping from his right nostril. And when you have a look, there's a bleeding site in the septum. So what's the most appropriate management step? So the answer is nasal cautery, which is C. And I think the best way to go through all the answers is to look at the epistaxis ladder. So this is what we call the epistaxis ladder, which is it's just like the anesthesia ladder. It's a graduated approach to treating nosebleeds. So when someone with, and remember, nosebleeds are very, very common. Pretty much everyone would have had one at some point. And the vast majority don't present to hospital. So the first thing you do is you do a quick initial assessment, A, B, C, D, E, and you decide whether they need to go to resus or whether there's someone who can, be in minors, or if they're at home, do they need to go into hospital effectively. So the first thing you do is you bend your head forward and you pressure the fleshy part of your nose and you hold for about 15-20 minutes. Now, using ice is interesting. The strongest amount of evidence is actually ice in the mouth rather than the neck. So I apologize for that typo on the slide. So ice in the mouth is the strongest amount of evidence in trying to help stop nosebleeds. And I'll probably try this for about 20 minutes or so, 20 minutes or half an hour to see how it works. If that doesn't work, you can then try using some lignocaine with phenylephrine with some cotton wool and apply it into the nose and see if that stops bleeding. If that doesn't work, you then have a look into the nose and see if there's any points to cauterize. And there's a little area, which is right in front of your nose at the septum, where there's a congregation of venous plexuses that tend to bleed a lot. And then you use silver nitrate, which causes a chemical reaction, and that burns off the vessels. Failing that, you then probably need to come in hospital, and you need to have a pack put up the nose. And I won't go through the types of packs because there's loads of different types of them, but we tend to use the rapid rhinos, which seem to be very effective. If that doesn't work, then you need to upgrade the packing to either packing both sides or you use a posterior packing. And we tend to either use a long rapid rhinos or a Foley catheter. If that doesn't work, then you go for surgery. So, you obviously go through the ladder and you treat them step by step. So going back to the previous scenario, our 11-year-old boy has already had the conservative treatment. So the next step will be cautery. If that doesn't work, it will be packing. If that doesn't work, posterior packing. If that doesn't work, then probably surgery. Okay. Any questions about epistaxis? Okay. Why don't we move on? While you guys are reading through the question, just something I wanted to say that it's also very important to try and find out why they're bleeding. So epistaxis is more of a cause as a result of something, and that something is almost always anticoagulant or antiplatelet medications, trauma, but it can also sometimes be a presenting symptom for hematological problems. So not uncommonly we diagnose ITP or hemophilia or von Willebrand's disease as a result of this. So taking a very good history, medical history, drug history is vital, because you don't really, when you treat the epistaxis, you also want to treat the underlying problem. Okay, most people have answered E, which is clarithromycin. There's some people who have answered a few B's and D's. So let's look at the answer, which is E. So a 13-year-old girl is brought in for sore throat. She has a fever and has not been eating because of the pain. She's tolerating fluids. She's not had any other symptoms such as a cough or rash. She's penicillin allergic, unfortunately. She's got a RESPs of 99, SATs of 99% of air, heart rate of 100, a blood pressure of 120, and a temperature of 38.5. So there's some signs there that, you know, she's starting to feel the pinch of dehydration. Auscultation of the chest is unremarkable. And on examination of her mouth, her tonsils are covered and exudates bilaterally. Her neck is tender, and ear examination is unremarkable. So in addition to supportive measures, what is the most appropriate management? So this points towards a picture of tonsillitis, okay? Now, you don't know whether it's bacterial tonsillitis or viral tonsillitis because it's only been happening for the last 2 days. The other differential diagnosis would be Epstein-Barr virus or glandular fever, which can also give you a very similar picture, and it tends to present in young adults and teenagers. So she fits the criteria. So if they fulfill what's called a CentOS criteria, which I'll talk to you shortly about, then you think this is likely to be bacterial, and you look at the options of giving them antibiotics. Our first line is usually phenoxymethylpenicillin, 500 milligrams QDS for 10 days. So A would have been the right answer had she not been penicillin allergic. So clarithromycin is usually the next best alternative. Metronidazole may have a role if things are not settling. And then urgent admission to hospital if she can't eat and drink, or if she starts developing things like epiglottitis or a parapharyngeal space abscess, where she becomes very sick and has stridor and breathing difficulties, then she'll need to go to hospital. So most tonsillitis are viral, so most of them you can treat with paracetamol or ibuprofen. There is the CentOS criteria where you have tonsillar exudates, tender lymph nodes or lymphadenitis, a history of fever, and an absence of cough. And if you've got 3 out of 4 of these, then there's a decent chance of you having bacterial infection. Now, the commonest bacterial infection of your tonsils is group A strep, which is why we use phenoxymethylpenicillin or Pen-V. Okay, now if a tonsillitis is untreated, or sometimes even if it progresses quickly, then you can get what's called a quinsy, where there's an abscess that builds up in the peritonsillar space. And this causes a deviation of the uvula and a swelling of the anterior pillar. And you also get what's called trismus, where you can't open your mouth because of all the swelling affecting the pterygoid muscles. So these patients effectively need to be drained because it's an abscess, and otherwise they won't just get better antibiotics. So they tend to come into hospital. We are increasingly managing these patients as a daycare. So they come in, we drain them, and then we send them home with antibiotics. Okay, any quick questions about sort of tonsillitis? So what swells up in quinsy, it's basically the peritonsillar space. So you get a collection of abscess there from the inflammation. A few questions about epistaxis. If the bleeding stops at anterior packing, would you always admit? Depends on the policy of each trust. So we are very proactive in trying to take packs out, trying to see if there's a bleeding point we can stop and send them home. Some places would admit them. So it depends. Each hospital is different. There's been a recent study on this, and what we have found is that the more proactive we are in trying to stop the nosebleeds or trying to halt admissions, the better the outcomes. So as much as we can. If you couldn't see the area, would you try cautery? No, you only cauterize if you can see where it's coming from. Okay. Next question. I think we're kind of at the end now. It's probably just a few more slides. You guys must be getting quite hungry as well. So I won't hold you out much longer. Okay, so we've got the results. Most people have answered B and C, so there's equal split between B's and C's. So good answers, we'll go through them. This is an elderly gentleman who's got a swelling in the left side of the face. It's been slowly growing over 4 years. So that kind of tells you it's less likely to be something that you really need to be worried about, i.e. malignant. He's a lifelong smoker with a 56 pack year history. He's recently moved to the UK and reports a lesion removed from his right parotid gland approximately 10 years ago. So on the contralateral side, he had something removed. He denies any facial weaknesses, pain, dysphagia, fever, or facial loss. So that's very important that there's no facial weakness. And an examination is a well-circumscribed lump in the region of the parotid, which is mobile and non-tender. So the answer is actually a Warthin's tumor. Okay, so we just look at the scenario. You've got a slow-growing lump. He's got some risk factors where he's been a smoker. He's had something removed from the other side 10 years ago, and there's no reports of this coming back. So that's generally a good sign. He denies facial weaknesses. So if you've got a parotid lump with a facial palsy, that's a very bad sign. It's almost always cancer. And there's no pain, dysphagia, fever, weight loss. Again, pain with a facial lump, it's either inflammation, infection such as parotitis, which is a short history, but if pain with a lump that's been there for a long time, it's also not a very good sign. So we'll briefly talk about parotid lumps. They're fairly common. Obviously, we see a lot of it, so it's a bit skewed. 80% are benign, 80% are pleomorphic adenomas, and the second commonest one is a Warthin tumor. So why is this a Warthin tumor? The reason it's a Warthin tumor is because it's bilateral. Warthin tumors tend to be bilateral, or they kind of present sequentially bilaterally. What investigations? We always start with an ultrasound guided FNA. That's always the first line. CTs and MRIs, we don't really bother unless we suspect this is a deep lobe of the parotid and we want to try and find out where the extension is, whether it's going to the parapharyngeal space, whether it's going to the oral cavity from there, then we might get an MRI scan. So if it's a Warthin's tumor, it's benign, it rarely becomes malignant, so there's an argument to leave it alone. If it's a pleomorphic adenoma, we almost always take it out because there is a malignant propensity, which grows with time. So it depends what the diagnosis is, which is why getting an ultrasound guided FNA is very important. It helps us make a decision. And the treatment is a parotidectomy, and you almost always preserve the facial nerve. I mean, there's no reason why you need to sacrifice the facial nerve in a benign disease, unless the tumor is infiltrating it, by which you normally would have a preoperative facial nerve palsy already. So Warthin's is the commonest bilateral parotid tumor, and it's usually in people who have a degree of smoking. It's usually in the 5th, 6th, 7th decades of life. Okay, any burning questions? So it's neck lump. If a neck lump is mobile soft, does it make it less likely to be cancer? Yes, it does, generally. Is it Warthin's because this person's previously had a swelling on the other side, hence bilateral? Yes, that's exactly why. Okay, so I think this might be the last one, I'm not sure. For those of you who have asked questions that are not answered, don't worry, I'll go through them at the end anyway. So I will answer your question at the end. Okay, so most people have answered D, which is parainfluenza virus. Some of you guys have answered A, which is Haemophilus influenza. So let's look at the answer. It's D. So a 2-year-old girl is brought to A&E with a fever and noisy breathing. Her parents say she's had a cough and a runny nose for 2 days. In examination, there is a harsh rasping sound and inspiration. So that gives you an idea that what she's having is stridor, which is a harsh sound on inspiration. Whereas a wheeze is an expiratory sound and it tends to be musical. Her respiratory rate is 36, oxygen saturation is 95, and the temperature is 38.9. So she's, slightly tachypneic. She's got slightly reduced saturations and she's pyrexial. What pathogen is most commonly responsible for the likely diagnosis? So Haemophilus influenza is a bacteria, and this used to cause epiglottitis and used to kill kids with epiglottitis, but thankfully we have a vaccination program now which almost always eliminates this, so we rarely see it. We certainly rarely see it in young kids. What we do see is in some older people who've not been vaccinated. CMV, cytomegalovirus, doesn't really cause that. Epstein-Barr tends to cause sort of more glandular fever starter stuff. Parainfluenza viruses and respiratory syncytial viruses are your mainstay of sort of upper respiratory tract infections. And effectively, what this 2-year-old girl has is croup, which is generally caused by parainfluenza viruses. Chlamydia, pneumonia is not something we see very much in young kids, let alone in the upper respiratory tract. So croup is parainfluenza viruses, but it can also be caused by RSV or metapneumovirus and influenza. And what you get is swelling of the larynx, which causes airway obstruction and it causes stridor. And it tends to happen in fairly young kids over the winter. So if you've done a pediatric job or pediatric placement, then you'll find that, pediatric bays are filled with kids with bronchiolitis and croups over the winter. And come summer, they're all kind of fine. And if you do an x-ray, you shouldn't have to x-ray these kids, but if you do an x-ray, what you do see is a steeple sign where there's narrowing of the glottis as a result of the swelling. So in epiglottitis, it's usually caused by Haemophilus influenza. It's extremely painful and toxic, and the children are very sick, so they really look pretty unwell. Croup kids don't look all that bad. They have a barking like a seal barking like cough, but they generally are quite well in themselves. Obviously, there's a proportion of them that do get worse. Whereas epiglottitis, they look very sick. They're drooling, they're toxic, and you have to be very careful with these kids not to aggravate them or make them cry, because that means that they put their airway under stress and then it closes up the airway. A foreign body inhalation, this is very much depending on the index of suspicion. So a child with a history of stridor, you always have to ask the parents, do you think they could have swallowed something? Do you think something could be stuck there? And this is where you get an x-ray to try and find out. Laryngomalacia is a congenital issue where the larynx is floppy, and what happens is when they cry or when they breathe in, the whole larynx flops into the airway and causes them stridor. It generally is self-limiting. So sometimes the kids have problems feeding and they have failure to thrive, and then we intervene. Vast majority of them grow out of it within, I'd say, 6 months. Sometimes if they persist longer than that, then we do an operation where we snip the areoepiglottic folds to try and flop the larynx back on. I think that's pretty much the last one. So before we go into questions, I just wanted to introduce you guys into into a website, which is due to be developed in an app very shortly. It's called entsho.com. And it's effectively a site that was created by a few of us, probably about 8 years ago, or maybe even longer. And it's to help people who've got very limited knowledge in ENT, or who are new to ENT, or want to get a bit of extra knowledge, or you're starting a job in ENT, or cross-covering. It's got a lot of basic knowledge and also some advanced stuff. And it's got links to videos and images and a lot of resources. And conditions that you can just read up about. So, when the app comes out, you'll be very welcome to download it. And it gives you quick access to stuff when you're on the wards, or when you are seeing patients, or even when you're doing your revisions. So I just want to introduce you guys to that. And I am happy to take any questions. I think what I'll do is I'll quickly answer the ones that are here. So can you go over central versus peripheral again? So central effectively is neurological causes. So anything from sort of cerebral cortex to brainstem to cerebella. And peripheral is effectively anything that's outside of that. So your vestibular apparatus. Remember, your vision and your proprioception also contribute a fair bit to that. And they have links to both your peripheral part and your central part. So balance is quite complex. I don't really want to go through the whole thing today, but effectively central is is neurological, and brainstem and cerebellar, and peripheral is the rest. That's probably the easiest way of doing it. Can you manage Meniere's with prochlorperazine? You can manage an acute attack with prochlorperazine, but you can't manage them long term with it. So if they have an acute attack, give them a few days of Stamartil. But usually the attacks are hours. What causes horizontal nystagmus? So horizontal nystagmus is almost always peripheral in nature. And effectively, if you've got a underactive or inactive balance organ on one side, that can give you peripheral nystagmus. So it's almost always peripheral in nature. So vestibular exercises and therapy involves a set of exercises that are specially designed to help rehabilitate your body's balance, and they involve sort of movement, so proprioceptive leg movement stuff. They involve head movements, they involve eye movements, and it's trying to basically get your balance organs to pick up the receptors better and start rehabilitating all the inputs that go through. So can you tell which side the lesion is by direction of nystagmus? Yes, you can. So for example, nystagmuses are characterized by their fast beating phases. So if you've got a right-sided fast beating nystagmus, then the lesion is normally on the left side than the other side. So you can, for a horizontal nystagmus, you can't always for vertigo ones. It gives you an idea, but you can't always. Yeah, so I don't think leave that question out. Warthin's tumor needs surgery? No, so Warthin's tumor probably doesn't need any surgery. You have an option of leaving it, but what happens if you leave it is it'll just carry on growing. So it depends how old the patient is, how fit they are, etc., etc. If they are 90, you probably won't do anything about it. If they are sort of 60s or 70s, you tell them the chance of it being malignant is very, very, very low. But what could happen is they'll carry on growing. So it's up to them to make that decision whether they want to have surgery or not. Whereas with the pleomorphic, we'll almost always recommend surgery because there is a chance of it being cancer. So is a Warthin's tumor unilateral? Is that why this is an yes? So effectively, the reason why the answer to that question was Warthin's was because it was a bilateral tumor. Don't get me wrong, you can get a bilateral pleomorphic, but it's pretty rare. It's a lot commoner to have a bilateral Warthin's. So yes, we would take out a pleomorphic adenoma because of the risk of potential malignancy in the future. That's correct. How would you differentiate from whooping cough? So whooping cough is, again, not something we see so much anymore since vaccination came in. So I don't think I've ever seen whooping cough. I have seen diphtheria, which again people are vaccinated for and is almost eradicated, but you do see the odd case of it. Whooping cough, not common. So I'm not really sure how you would differentiate it. It's obviously in the list of diagnoses, and what happens, the list of differentials, and what happens is these patients with croup, if they're stable enough, they tend to have a swab, and the swab will give you the answer effectively. Is pleomorphic unilateral? Generally unilateral. It can be bilateral, but yeah. So just visited the website. Looks incredible. Thank you. Yeah. So hopefully you guys find it useful. Okay, that's fine. From Rebecca, that's okay. Yep. Salam sejahtera, Rebecca. Good to hear from you as well. Samuel Kant, what is the first investigation you do for a person who comes in with persistent hoarseness? So we take a history, we're examining them, and we'll almost always put a camera through their nose into the back of their throat. So it's what we call a flexible nasal endoscopy. That's what we do. When you say bilateral parotid Warthin's, does that mean two tumors at two different times, or are they at the same time? So they can happen at the same time. So not uncommonly, they'll come with swellings on both sides. And obviously, a lot of people think of mums, because mums also comes with bilateral swellings, but with mums, it's painful and it's tender, and there's more of an inflammatory feel to the lump than it does with Warthin's. So Warthin's is a soft lump in that region. How would you differentiate Warthin's from pleomorphic based on signs and symptoms? So Warthin's are usually soft. It can also be hard. It can be hard. But it tends to be softer. Pleomorphics is hard, and the ultrasound in the FNA gives you the answer. So when you're doing your OSCEs, you would examine the neck, and both will be part of the differentials. Remember that just because something is arising in the parotid region, it does not mean it's coming from the parotid. So you also have to, mention lymph nodes, and you have to mention sebaceous cysts and dermoid cysts and all this other kind of stuff. But this is where you use your surgical sieve to go through it. There was a place where we could access ENT SPSG. I think Yezin will talk about this very shortly once we've gone through all the questions on Quesmed. ENTSJ.com website does have some questions. It's more relevant for postgraduate examinations. I don't think we've got anything at a medical student level. But this is something that Yezin can talk to you guys about. I think that's the last one. If there's nothing else, Yezin, back to you.
Thanks very much. Yeah, so thank you so much, Anath. That's amazing. Wow, really, really good. I think, do you think you'd cover more or less the vast majority of the ENT curriculum?
Yeah, I mean, I think, unfortunately, ENT is not very common in medical schools, but is very common in real life.
Yeah.
So I'm not quite sure this is an ongoing battle between ourselves and medical school curriculums to try and incorporate more and more of it. But, there's only so much they can do. So most medical schools will probably have a week or 2 weeks at tops. Mm-hmm. Sometimes you'll have placements where you are, in a surgical block for 10 weeks or 12 weeks, and then ENT is thrown in part of that. Mm-hmm. So as a result of that, there's actually not many questions that will arise from an SBA or EMI or MCQ point of view. But the few ones that do come are generally to do with neck lumps, to do with ear stuff. You can have a few bits on, nosebleeds, some on airway stuff, and a few things on hearing. So I think we have covered most of it. I'm trying to think if there's anything that's really burning that would have missed. Obviously, they could ask you questions on carotid body tumors and all that kind of stuff, which are the rare bits, which medical school exams like to ask you. But again, they come under the neck lump sort of remit and region.
So
So
the questions on the site, I think you can also access them. So from the Quesmed website, you can access them via the free questions bit, and you find the ASCENT questions, so the ENT questions. So basically, we worked with a group of ENT consultants and registrars, and they've made essentially 50 free questions. So on the Facebook group, I'll put up the link. And then I guess the last thing is to please fill in the feedback for Anath, so that he can put some stuff on his portfolio and all the continuing learning stuff. So I'm sure that will be useful. It'll be good for us to know what's going on. And thank you very much, I think. And Savannah, anything to add on your end?
Nick, just a massive thank you for taking the time out for creating and delivering this session. So thank you, and answering everyone's questions. There were 59 of them, guys, so a massive thank you for that.
Not at all. Pleasure. Well, it's a pleasure to be invited and to be able to do this for you guys. It's a very difficult time for everyone, and especially if your placements and lessons have been halted, then this is a good way of doing it. So congratulations to Yazin and Savannah for organizing it. And yeah, happy to do this in the future if you guys need to.
Thanks, Anath. All right.
Have a lovely evening, everybody.
Okay, have a good evening.
Bye.